I thank the organizers for this opportunity to share a few thoughts on both diabetes and newer insulin in primary care. My special thanks to Dr. Sanjeev Singh Yadav for this opportunity. Request all the audience to please stand up for a minute. Can all the audience stand up for a minute? I think one of the important factors in our day-to-day life which is contributing to diabetes is a sedentary lifestyle. Just to break the monotony of sitting which you have been doing for some time, just a stand up. So we all need to prevent diabetes, and then we have taken the first step by getting up from our chairs and then trying to move around. Thank you so much. You've been such a wonderful audience. Please sit down. Thank you. Diabetes in primary care is a very important factor which we need to take into account. India is now called as the diabetic capital of the world, and Hyderabad somehow is holding the distinction of the diabetic capital of India. So we need to take urgent steps to prevent, treat diabetes very effectively. Just yesterday at the Golden Jubilee Conference of the Research Society for Study of Diabetes in India, 2022 clinical practice guidelines by an Indian body have been released. I urge all of you to go through that so that we all manage diabetes in a very uniform and a practical way so that our patients benefit. Moving on to newer insulins. All of us are aware of these two wonderful Nobel laureates, Banting and Best, who discovered this important hormone, insulin, on 27th of July 1921, for which subsequently they received the Nobel Prize. And today, we have come a long way from treating our patients with diabetes. And such was the joy, as you can see in that newspaper that time, the headline reads, "Toronto doctors on track of diabetes cure." We are surely moving towards a good control of diabetes and maybe in some instances, cure or remission of diabetes, which I should call. What is this? Anybody? Lot of postgraduate students. What is this? Somebody wants to get up and say. What is this? Anyone? You have to overcome your inertia of getting up and standing. Let us make this an interactive session. What is this? Anybody? Am I not able to hear, or you are not speaking? What is this? All of us are aware that this is the molecule of proinsulin. We have the A chain, B chain, disulfide bonds, and the C peptide which is binding them. So insulin is a small globular protein, as all of us are aware, containing two chains, A and B, and it is stored in the beta cells as a zinc stabilized hexamer, and it dissociates in the bloodstream to function as a zinc-free monomer. All of us are aware that insulin actually facilitates the entry of glucose. So whatever we are eating is actually being utilized by the body only in the presence of insulin. So coming to newer insulin, while I was an undergraduate, we started using insulin which were animal insulins. We've had porcine insulin, we've had bovine insulin, then came the semi-synthetic insulin. Finally, you had the recombinant technology being brought into use in the production of human insulin, and now you have multiple insulin analogs. So what are the advantages of newer insulins? Because they are refined, because they are pure, you have less allergic or immunogenic reactions. The autoantibody formation to insulin is much less, so you have less resistance. They are very well tolerated. And because of the different tweaking which is occurring in the insulin molecule, they are actually being tailored for different category of patients. We are trying to mimic the physiological release of insulin in the body, wherein you have a basal insulin going on, and then boluses for every mealtime insulin. Now, you can have an insulin pen in your pocket, and it becomes very easy to administer. The needles which are coming nowadays are very fine, and it is almost a painless injection. People are scared about insulin because they feel that is end of the story. A lot of patients can be managed with diet and lifestyle modifications alone. Some will require drugs, and then some will require insulin. However, insulin may be required early on itself when you diagnose diabetes. A lot of times when people come to us with health checkups and find a very high sugar, we give them insulin for a small period of time initially to rapidly control the blood sugar level and then switch them back to oral drugs. This is important because early control of diabetes is important because there is a concept called as metabolic memory, wherein your early control actually portends a favorable prognosis compared to a poor early control initially, which has a lot of complications later on. So as I said, the insulin will have less antibodies. Injection is associated with fewer skin reactions. They are more rapidly absorbed and less degradation occurs at the site of injection. The human insulins are developed by the recombinant human technology and are derived from bacteria or yeast, bacteria like E. coli. All of us are aware of the different types of insulin. It can be short-acting insulin, which is the regular insulin. You have the intermediate-acting, the NPH insulin. Then you have combinations of insulin where you have a mixture of the short-acting and the intermediate or long-acting, which is called as a premixed insulin. Whenever you write a premixed insulin, it is a good habit to mention what is the percentage of the mixture. Is it 30/70 or 50/50? Now, the human insulin is now being further modified by certain changes in your amino acid sequences to alter the property of the insulin or attachment of certain molecules to alter the release of insulin so that we get a desirable effect. So you have fast-acting insulins which act faster than the short-acting ones. It includes Lispro, Aspart and Glulysin. Now we have a very ultra-fast-acting insulin which is called fast-acting Aspart or Fiasp. You have a longer-acting versions called Detimer, Glargine, Degludec and then U300 Glargine. So by this, we are trying to have different effects of insulin so that we control the sugars by causing less hypoglycemia and which is more convenient. Somebody who is not sure of his meal time can use these insulin because this insulin can be taken with the food or sometimes just after food. Because if you take insulin and you are not able to eat on time, as we see in the doctor's profession where you get a call suddenly you have taken insulin, you are not able to eat your food on time, you are not at a risk of hypoglycemia. Because they act for a very short period of time, the risk of hypoglycemia again is important. There are certain professions where the hypoglycemia has to be minimized and therefore you need to know the type of insulin you are using, their characteristics and then use them appropriately. Regular insulins are generally given about half an hour before food, but the newer insulin like Fiasp need to be given maybe 5 minutes before food because they act very fast and if you give them half an hour, by the time you start your meal you are already hypoglycemic. So certain properties of insulin you need to know very well. So are there any novel routes of administration of insulin? Because people fear the injection, the pain and they are averse to taking insulin because of that. Are there other varieties of insulin available? Yes. Inhaled insulin has been developed, which I will discuss in a short while. Oral insulin also has been developed. However, the problem with oral insulin was it was getting degraded fast, acting after a long period of time and therefore it was not actually having its desired effect. However, as recently as August 38, 2022, the University of British Columbia has presented a paper where two researchers have come very close to developing an oral insulin molecule in rats, showed that it acts very rapidly and has a very good effect. And hopefully if we can get an oral insulin, our dream towards achieving a very natural way of taking medicines actually comes true very shortly. As coming to the inhaled insulin, which is available, there are two which were available. One is the older one, because of a lot of side effects, has been withdrawn. But the newer one, Afrezza, which is having technospheres of insulin, can be taken by an inhaler and then it is actually effective. However, the percentage of insulin which gets absorbed is less. Some may have lung-related problems and then you need to monitor your lung function very frequently. What you see on the right is the device for taking this inhaled insulin. However, it is not a very practical way of doing it because of the kinetics which are very much involved. Based on the dosage which you use, you can give the units based on this inhaler. And next, coming to insulin pump. Insulin pumps are very well available now. You can put a pump you can program the pump and then leave it so that based on your meal timings, it will give a bolus dose and otherwise keep giving you a basal dose so that you're mimicking or sort of mimicking the physiological insulin release in the body. However, the person using should be a little bit aware of how to use that, and then you should be always on the lookout for a pump failure or pump malfunction so that you don't get into hypoglycemic problems. So I won't go through this insulin because I've just discussed with it. We have short of time and then I want to conclude very fast. So this slide basically sums up the different categories of insulin, how they act, what is the onset of action, when it peaks, and what is the duration. And based on these characteristics, you decide what type of insulin is best for your patient. In a primary care setting, your regular human insulin is probably good enough for most of the patients because the newer insulin analogs being very costly, patients may not be able to afford it. It is important that patients take the drug rather than what drug they are using. A fancy drug may appear very good, but if it is not used at all because of the cost, it won't serve its purpose. So, based on your patient profile, the affordability, and what is his profession, age, risk factors of hypoglycemia, you need to be very wise in choosing what type of insulin you are going to give that patient. People say, why take insulin daily? Are we having or moving towards a weekly administration of insulin? This phase 2 trial involving iCodec, which is a once weekly insulin, is being done, and it has shown promising results. And maybe in the near future, you will have a once weekly insulin which we can use, and our patients will get a relief of pricking only once a week. This is what is involved in taking insulin. You have the pen, you need to fill it with cartridges, you need to apply the needle, and then the pens are very user friendly in terms of delivering the dose, and then you need to be aware of how a pen works. So it is a very good habit to show how to load a pen, demonstrate that first dose of insulin in front while the patient is there in your OPD so that he is quite comfortable and the phobia associated with insulin and the needle goes away. So when you spend about 30 to 45 minutes for the first time when a diabetic patient meets you and then clarifies his doubts, he becomes reassured and leads a normal life. Thank you so much for your patient attention.